So a lot of people liked my pharmacist intervention series, so I'm gonna have part 5 right now. Another intervention that I've made is I had a patient given Eliquis, which is a blood thinner. It's very expensive. It's about $500 to $600 out of pocket for a 30-day supply. They just had a blood clot, so with Eliquis you need to taper it, 2 tablets twice a day for a week, and then you do 1 twice a day continually. If someone had like an unprovoked clot, meaning we don't know what caused it, you keep them usually like lifelong or until the bleeding risks outweigh the benefits of the anticoagulant. So $600 about. Patient had insurance, but insurance denied to cover it until a prior authorization was filled out. A lot of these patients come from like the ER or somewhere where the provider is either non-responsive or does not do a prior authorization. And this is a very time-sensitive matter. So I had a coupon card for them for a free trial. So I was able to get it to them at no cost, get them started on the blood thinner, counsel them on signs of bleeding, signs of clot, interactions, what not to take with it, sort of like precautions, like you fall, you hit your head, go to the ER, you could have like an internal bleed, stuff like that. So, and then I of course said like you're gonna need to find like a hematologist or some sort of provider to do a PA for you to continue to take this medication for as long as you need to, either like a cardiologist or whatever caused the clot, sort of that kind of specialist. I had a patient who had aplastic anemia and they were on cyclosporin for that, and they got COVID. So this patient's immunosuppressed. They need to be on Paxlovid to decrease the risk of mortality and hospitalization. However, Paxlovid interacts with a lot of medications that are 3A4 mediated, cyclosporin being one of them. So you can get toxicity if you don't dose adjust your immunosuppressant with that. So that's not good. It has a very narrow therapeutic index, meaning that the dose that you need for therapy is very close to the toxic dose. So I recommended a 75% dose reduction in the meantime of that cyclosporin. And then, of course, I recommended to follow up with her hematologist to draw levels and monitor that, see if they had a different recommendation from that, because it was like after hours on the weekend they had to take this medication within a certain amount of time, and they had no access to their hematologist. So I recommended to dose adjust for the time being before they could follow up with their hematologist in order to avoid toxicity, but also stay on the medication that she needed to be on.